Welcome to this brief session on the venous drainage of the lower limb. This is part of a lecture series on topographic anatomy of the lower limb. And in this particular session, I'm going to discuss the venous drain of the lower limb. It's going to be a brief session just focusing on the vein. To start with, the venous drain of the lower limb is in two patterns. The superficial pattern of venous drainage and the deep pattern of venous drainage. Let's begin by looking at the superficial pattern of venous drainage. The images shown here are images of the subcutaneous tissues, neurovascular structures in the subcutaneous tissue. What we predominantly see are the superficial veins as well as the subcutaneous nerves or the cutaneous nerves. I'm focusing on the superficial veins. The superficial venous system of the lower limb is via what we call the saphenous venous system. The saphenous system of veins consists of two veins. One very long one, therefore called the long or the great saphenous vein, shown in the first image, and another one short one, called the short or the small saphenous vein, shown in the second image. Let's begin with the great saphenous vein, or otherwise known as the long saphenous vein. The great saphenous vein begins on the medial aspect of the foot. It is formed by the union of what we call the medial marginal vein and the medial aspect of the dorsal venous arc. Now, what is dorsal venous arc? The dorsal venous arc is basically anastomosis of veins that drain the digits. So those veins that drain the digits, they join together and form a venous arc there that we call the dorsal venous arc. So this dorsal venous arc has a medial aspect of the arc and a lateral aspect of the arc. The medial aspect of the arc, together with the medial marginal vein, join on the medial aspect of the foot to form the great saphenous vein. This great saphenous vein runs upwards, anterior and superior to the medial malleolus, then runs on the medial aspect of the leg. At the level of the knee, it passes behind, usually about 100 medial to the medial border of the patella. And then in the thigh, it ascends superiorly and slightly anteriorly as it goes upwards all the way to the roof of the femoral triangle, at which point it then enters deep to drain into the femoral vein, which is a deep vein. This opening on the fascial artery that allows the passage of the great saphenous vein is called the saphenous opening or the saphenous hiatus. Along its course, the vein receives several other superficial veins. Some of them are named, some of them are not named. It also communicates to some extent with the small saphenous vein. Some of the named branches, or rather named tributaries of the great saphenous vein, are these ones just before the vein terminates at the femoral vein. The junction between the great saphenous vein and the femoral vein is otherwise known as the saphenofemoral junction. So near the saphenofemoral junction, there's some superficial veins that join the great saphenous vein. We have the superficial external pudendal vein. The superficial external pudendal vein drains the external genitalia, so this is it. We have the superficial epigastric vein, which drains the subcutaneous tissue of the anterior abdominal wall on the lower side. And you have the superficial circumflex iliac. Those three superficial veins are basically accompanying the branches of the common femoral artery, which have the same name. But remember, the arteries came from the common femoral artery. The veins that accompany those ones now join the great saphenous vein before it terminates at the saphenofemoral junction. That is great saphenous vein. How about the small saphenous vein? The small saphenous vein begins on the lateral aspect of the foot. It also begins by union of the lateral aspect of the dorsovenous arc, the union of that with the lateral marginal vein. So the lateral marginal vein is the vein that drains the lateral margin of the small toe. The two meet to form the small saphenous vein. Small saphenous vein runs below the lateral malleolus and then behind it to ascend on the posterior aspect of the leg all the way to the roof of the popliteal fossa, at which point it pierces the deep fascia and terminates into the popliteal vein. So that's the course of the small saphenous vein. If you are to describe the territory drained by the small saphenous vein, we can say it is the small toe, lateral margin of the foot and the small toe. We can combine that together. Then the heel and the posterolateral aspect of the calf. Those three territories are drained by the small saphenous vein before it terminates into the popliteal vein within the popliteal fossa. There's a nerve, superficial nerve, that runs to the small saphenous vein. We call the sural nerve. And this superficial nerve that runs with the great saphenous vein is called the saphenous nerve. Saphenous nerve is a branch, a terminal branch of the femoral nerve, while the sural nerve here may have multiple contributions in terms of naming system, a bit variant, but there is contribution from the tibial nerve, which gives you the sural nerve itself, and the sural communicating coming from the common peroneal nerve many times. Occasionally, the superficial and the two superficial venous systems communicate with each other. So great and the small saphenous vein may communicate at some point. But importantly, the superficial veins also communicate with the deep veins through some particular regions via some veins that we call the perforating veins. So remember, superficial veins are outside the deep fascia. The deep veins are within the deep fascia, within the muscles. We have some veins that connect the two, which we call perforating veins. Generally speaking, blood will flow from superficial vein to the deep vein. The perforating veins are at particular regions of the lower limb. There are some which are a bit constant, and there are some which are not very constant. But the rule of the thumb is that blood flows from superficial venous system to deep venous system. So those communications are very important. They're at particular levels before the superficial vein actually terminates into the deep vein as a whole. I want to say something clinical about the superficial veins before we discuss the deep veins. The first thing I want to talk about is what we call varicose veins. Varicose veins are basically a disease of the superficial veins, and they manifest as engorgement and dilatation of the superficial veins. How do they come about? They are caused by failure of the valves. Now understand that if blood is flowing from the lower limb back to the heart, it must flow against gravity. And so for that reason, blood from the lower limb struggles to reach the heart. There are some mechanisms, however, that make this be possible. One of the mechanisms is the presence of unidirectional valves, which look like this one. So such valves allow blood to go in one direction and prevent backflow. They are present at multiple segments of the superficial veins. What therefore happens if the valves of a perforating vein or the valve of a superficial vein become incompetent, like in this one? If you have an incompetent valve, that valve will allow backflow. And if it allows backflow, it means that that segment of the vein will hold a lot of blood, and so it will expand to become tortuous. When that segment becomes tortuous, the other adjacent segments will also become tortuous again, and dilated and tortuous. The more the segment that become dilated and tortuous, the more the number of valves that will also fail. Because as the vein expands, the valve around that region will start to fail. And when that valve fails, it expands, allows expansion of the distal segments. Those distal segments, again, their valves will fail, and so on and so forth. It becomes a very vicious cycle. So in long term, what we notice are some tortuous, dilated superficial veins. That's what we call varicose vein. You can check out on how they're managed. The other thing I want to talk about superficial veins, which is clinical, is what we call saphenous venous cut down. Now, venous cut down is a procedure of dissecting out a vein, identifying the vein, cannulating that vein to perhaps administer fluid in an emergency situation. One of the things that may predispose to this kind of a scenario is where perhaps somebody has become hypovolumic, which means that the volume has gone down, the blood volume has gone down, so the blood pressure is low, and that has made it difficult for you to identify the superficial veins that usually just see beneath the skin and you cannulate usually. So if those veins are not visible, or for whatever reason you are not able to give fluid in the normal cannulation way, you can do, as an emergency procedure, a venous cut-down procedure. For you to perform a venous cut-down, it relies on some important concept, that you know where a particular vein is usually found. Because remember, you are most likely not seeing it, and especially if you don't have an ultrasound machine, you are not seeing it. It's even collapsed, perhaps. So we're just relying on the anatomy. And so where do we find such veins? Great saphenous vein becomes a very good offer because we know its commonest landmark. We know that if we go to the medial here, slightly anterior and superior to that one, we'll find the great saphenous vein. That blue line represents the course of the great saphenous vein. So in the venous cardon procedure, usually you make a transverse cut, superficial transverse cut, on the area where you expect the vein to be. Once you've made that superficial transverse cut and perhaps expose or retract the skin, you will definitely see the vein. And especially if it's a transverse cut, you have a wider area to check. You then identify the vein, and after lifting the vein up using the instrument that is available, you make a nick on the vein, perhaps about 40%, 50% of the vein. You don't cut the whole vein. And that will expose the lumen. It's on that lumen that we insert a cannula and, of course, give you a fluid. I've described it in a long way, but remember, this is usually an emergency procedure. So we can use that to rehydrate somebody. Those are superficial veins. Now let's talk about the deep venous system of the lower limb. The deep venous system of the lower limb will be the veins that accompany the arteries. So deep venous system follow arteries. They are easier to describe because the deep veins follow arteries and they have the same names like that of the arteries. So if you have a femoral artery, then we have a femoral vein. If you have a common femoral artery, then you have a common femoral vein. If you have a profunda femoris artery, then you have a profunda femoris vein. So basically, the deep veins follow arteries and they have the same names. However, let me say something. Below the level of the knee, and occasionally for some smaller deep veins, like those ones that will accompany the profunda femoris artery, or the branches of the same, those veins exist in form of what we call vena comitante. Now, what's vena comitante? Vena comitante is the existence of two or multiple veins around one artery. Those two or multiple veins are usually communicating with one another, like this manner shown here. So the two or more veins that accompany artery communicate with one another. And that's why most of the time we want to talk about a vascular bundle. If there's a neuron there, then we talk about neurovascular bundle, rather than just pinpointing that this is the vein, because there'll be multiple veins. Well, alternatively, you can talk about the comitante. So the veins below the level of the knee tend to be in form of comitantes. So we talk about anterior tibial vena comitante, posterior tibial vena comitante, dorsalis pedis vena comitante, and so forth. What's the importance of vena comitante? Two things. Remember, these veins still have valves. The pulsations of the artery help to push the segments of blood within a particular region limited by two valves. So when the artery pulsates, it pushes the blood within a particular segment upwards according to the direction that the valves will allow. So this arrangement promotes venous return because the pulsations of the artery are translated onto the segments of vein limited by valves. And in so doing, the pressure the artery exerts in those segments will make blood in those segments to go upwards in this particular context. The other advantage of the vena comitante is that the blood in the veins is from the periphery and relatively cold. The arterial blood is from central, and so it's relatively warm. The arterial blood has the opportunity to warm the venous blood before the venous blood reaches the heart. So it's a mechanism of warming venous blood before the venous blood reaches the heart. But on that note, did you know that it's actually, if you want to become warm, maybe even relatively faster, if you're feeling cold and you want to be warm, it's much easier, or it may be faster, to put your feet on a warm thing, like a warm water bottle. If you put on your feet, you might even feel warm much faster than if you are to hold that water bottle on your tummy or something. Because of the same concept, the blood in the peripheries are cold. So if you can have a way of warming it, then that warmth will be translated to the central region easily. Great. So that's the venous drainage, the superficial venous drainage, and the deep venous drainage. I want to say something about the deep veins and something called deep venous thrombosis. Deep venous thrombosis is a disease of the deep veins, as the name suggests. Thrombosis is basically clotting of blood within an intact vascular system. There are things that can promote to thrombosis, a concept we call the virtuous triad, tells us that 3 things may predispose to thrombosis. One is injury of the endothelium. So if you have something that injures the blood vessel, the inner line of the blood vessel is endothelium, that can cause clotting within the blood vessel. Another thing is if there is venous stasis. The blood within the vein is not flowing as fast as it should be. And the third cause would be what we call hypercoagulability state. Perhaps there are a lot of clotting factors circulating within the blood of this particular individual, and so that blood has a higher tendency to clot. We call those 3 the virtuous triad: endothelial injury, hypercoagulability state, and venous stasis. Whatever the cause of clotting, let's say blood clots in the deep veins. What's the danger of that? If blood clots in the deep veins, it can remain there or it can be dislodged. If it becomes dislodged, remember, as the veins go back, they become wider and wider. So if such blood clot becomes dislodged, then the chances of it running all the way to the heart is very high, because the vessels become wider and wider. So the clot, if it managed to pass through this small region, then it becomes easier for it to pass the other segment as it goes back to the heart. It can pass through the chambers of the heart as well, the right chambers, that is, and go to the pulmonary arterial system. When it goes to the pulmonary arterial system, remember, the vessels now become narrow again as that blood enters the lungs. The clot may get stuck now in the lungs. And that's what we call pulmonary thromboembolism, PTE, which is usually a medical emergency. Now, how does DVT present? Most of the time, DVT will present as unilateral limb swelling, usually very painful, and it's unilateral swelling. Most of the time, the things that will predispose to DVT will be, in our context, venous stasis, perhaps for this patient who has not been walking around a lot, because they are post-surgery, they may get that DVT. Or pregnant women, they may be predisposed to DVT because of the pressure the uterus applies on the veins, will predispose them to venous stasis and the like. All right, so that is the venous drainage of the lower limb. Our next topic will be on lymphatic drainage of the lower limb. Thank you.